Good. We have. Thank you very much. We have allocated time at the end of this meeting to respond to questions received in advance from members of the public, and we have 10 members of the public signed up to attend. So, may I please move then to conflicts of interest? Could you please let me know if you have any conflicts of interest to register or in relation to today's agenda? Thank you. Minutes of our last meeting held in public on the 21st of February and matters arising. Any comments or questions? I'll take those as accurate and approved. Thank you very much. And may I turn now, please, to Fiona Edwards, our Chief Executive, for her update.
Thank you, Chair. Good afternoon, everyone. So we're at the beginning of the new financial year for the National Health Service in 23-24, after 9 months of operation as an integrated care board, and probably some of the most turbulent times for public service, particularly given the pandemic recovery, the cost of living, the challenges and the scale of industrial action evidence, particularly last week with the General Doctors' strike. So, and it has to be said, our system colleagues and our staff have yet again continued to work superbly. We've managed our way through the recent bout of industrial action, but we've heard that the Royal College of Nursing has voted against the pay proposal, whilst Unison has voted for. So we've still got more industrial action ahead, and it's probably going to get more challenging, not only because of the NHS, but the wider public service as well, so schools and education, for example. So, it's really important, whilst we weathered last week, particularly, that has had a consequence with the cancellation of thousands of appointments for our residents. And so the pain and distress of the industrial disturbance is felt directly by patients and their families and our residents in Frimley, as well as our staff and ourselves as leaders. And it continues to disrupt our ability to really focus on delivering our plans, both for the longer term, as we've been debating as a board, in terms of our strategy that has just gone public from the Integrated Care Partnership, for really addressing health inequalities and reducing those gaps over time, and really focusing on a whole system mobilisation and vision, which is citizen-led and engaged. All the time we're engaged in such disturbance and arguments internally in the NHS. We're held away from being able to progress as rapidly as we'd like, but I think it's really important to thank everyone for their goodwill during a very difficult time, whilst also noting it's not necessarily sustainable, given it's going on for a long time. As chief exec colleagues across the NHS have been saying, the scale of disruption and distraction to just keep the show on the road is of an order none of us have experienced in our lifetimes and careers. But our staff continue to be wonderful and provide, and I get constant comments and feedback of great response and care, in spite of the number of cancellations that people are having to experience as well. So I think that's the tone of that set, really. Thanks.
Thank you. Can I invite colleagues, they want to make any conclusions at the moment? Hello, thank you. Really happy with that update. Could you give us a couple of thoughts on the Hewitt review, which came out a couple of weeks ago, just how that's landing, what you think might happen next?
So the Hewitt review is a recent publication as a result of a piece of work led by Patricia Hewitt, who past Secretary of Health and current chair of an integrated care board in North East of England. I'll get the patch wrong by naming wrongly. And she was commissioned by the Chancellor of the Exchequer and the Secretary of State to review integrated care systems working with a view to really looking what else could be done to support our development and delivery. And so she's come up with quite a wide-ranging report which reinforces the importance of the model that we're developing in partnership with local authorities, the importance of evolved approaches and fewer national targets and direction from the NHS, which can often be at odds with integrated local bottom-up, if you like, partnership working. I would say it's landed quite quietly because it was published at the same time as some pretty devastating news around social care. So my sense is it's had a quieter landing than might have been hoped for, but it reinforces the direction of travel. We've got a confederation meeting to look at the follow-up of that in the next couple of weeks as well. The ripples have not been far away.
Other comments, questions? Thank you. Priya, just to say, I think sometimes the sound's going in and out a little bit for our public colleagues. If we can pick up and to the hour, that will help people just hear everything that's been said. Thank you. A reminder to us all. Thank you. Then I'll hand over now to Sam Burrows, please, for our first agenda item, emergency care update.
Thanks, Priya. This is our regular item that we take when we come together as a board to look at the current position in our urgent emergency care services. Papers have been published in advance, and I'm assuming that members of the board have read them, but I will just direct the board to some headlines, which I think are helpful to comment on for inviting any questions or further comments. So, firstly, very much as Fiona just described, the system is still under significant pressure in urgent and emergency care services. And to be clear, whilst we often talk about that through the context of our emergency departments, it is not purely limited to that part of our system. It also includes our same-day primary care services, 111, 999, ambulances, and other parts of our service as well. You'll see on the third slide in the presentation that from the shape and the trend of those charts in front of you, you can see the pressure very clearly, that patients are waiting longer to be seen, and that the amount of time it takes to move patients between different settings of care, such as from ambulances into hospitals, is going up. And I think really, as Fiona just set out, that's something we hear about frequently as well. In response to that, we have opened some significant additional capacity across the system. On slide 4, you can see that's very much described and graphically shown around our bed capacity. We have an open capacity elsewhere in the system as well, which I'll come on to in a moment, but we have had to ensure that we have that additional capacity in the system to meet our patient needs. Clearly, of course, when you open additional capacity, there's the importance that it's able to be used and the patients don't stay any longer as a result of occupying those beds. So the system as a partnership has continued to work, I believe, really well together over the past few months to address the length of stay of patients in our acute hospital services, and that really is a multi-partnerial effort. You'll see on slide 6 the description of a number of events that have taken place since last autumn. Multi-agency discharge events, or MAID as the common acronym would show it, where we have set up a number of interventions between partners in our services provided by local government, community, primary care, and our acute hospital services as well, to ensure that we do keep that length of stay as low as possible and the patients stay for an appropriate length of time when they're in our secondary care setting. You'll see the impact of that on slide 7, which shows very clearly that our complex discharges from hospitals have risen by a double-digit figure in percentage terms over that period, which we are attributing directly to the impact of those MAID events and partnership working. There are still challenges, clearly, particularly in parts of the geography, some inside, some outside our ICS geography. But I think we should acknowledge as a board the positive progress that's been made in that space. I did want to draw your attention as well to the fact that we've opened additional capacity in our preventative care services and our primary care services too. Not all of these are our traditional bricks and mortar services. We are innovating at pace around trying to support patients stay out of traditional urgent emergency care settings, again, where it's appropriate to do so, using things like virtual wards, remote monitoring, and other technological innovations that we have available to us to try and keep patients healthy and well in their usual settings, whether that's at home or in a care home, for example. Looking forwards from where we're currently sat today, we've finalised our 23-24 operating plan, which includes a very specific section around our urgent emergency care operating plan for 23-24. That's involved, again, really positive joint working between our organisations to take some realistic assumptions and capacity plans around what we are going to need to provide in the year ahead to best meet the needs of our population. The board should note, as set out on slide 10, that the 4-hour standard, which has been in place for the best part of 2 decades as a way of measuring urgent care performance, is something which this system will begin to use as a standard measurement again from May of this year. For the previous period, we've been piloting a different way of measuring performance in urgent care. From May, the 4-hour standard will come back into effect in this system, and we'll continue to keep the board updated on our performance against that 4-hour measure when it does so. Finally, just finish with the final headline, which is that, as Fiona set out, we have had several periods of industrial action over the last few months. You'll see the detail of that set out on that final slide, and we are expecting further industrial actions come as well, which clearly provides an additional challenge to our ability to meet patient need in urgent and emergency care services. There's one final point I'd like to make, which isn't in the paper, with apologies, but it's important that the board is aware of this, and it'd be helpful if it could be minuted, please, which is that for 22-23, this particular integrated care system was able to meet its national EPRR core standards and is fully compliant with the statutory requirements in that area.
Thank you very much, Sam. Colleagues, comments, questions?
Thank you, Priya. Sam, thank you very much. As always, these updates are so valuable. What I'm really pleased to see actually is the fact that we can deliver care differently in this particular presentation, because I think you're right that the entirety of the system is under pressure, including our secondary care colleagues. But what I like about this is that the system has put an investment into doing things differently, things that we've learned from the pandemic. So it's good to see that actually the capacity in community services, which is primary care as well as our community partners, are creating capacity, and it's good for it's good for the public to understand that we're not trying to avoid ill people going anywhere. What we're trying to do is manage the illnesses or the problems in a different way, but in the right space and safely. And so it's really good to see that there's been investment with regards to things like remote monitoring, so that patients can stay in their own home, but they're safely managed. And actually what we're doing is we're saying that we're managing the risks of patients in a very different way. And I think that's really important to at least kind of remind and reiterate, because that's where we probably need to put our investment in, or move our investments about, because our secondary care colleagues can then look after the most unwell, and we can manage the risk and actually encourage the public to stay well and maybe get more involved in their care because they are using technology in partnership with the community. So it's so good to see that slide, and I'm kind of looking forward to seeing more of that, because I think that will transform the way we look after patients across the system. Right care in the right place.
Kind of points to me. Thanks, Bruce. So I think just pick up from our conversation at the last board. I think we do need to be clear when we're bringing the strategy back. think we agreed last time, we've had a strategic review of urgent care, but we now need to be really clear around the kind of timescales for nailing that strategy down. I think Prash's right. I really welcome the improvements in recent weeks. And, you know, our focus this year will need to be on that transformation to deliver the improvements in length of stay for patients that we'll need to ensure we've got flow going through the system. And I guess just to flag as well, I mean, I welcome the return to 4 hours and the clarity around that, and that's helpful. It does bring with it risk. You know, one of the challenges around the 4-hour standard is the high rates of admission that you get to dispose patients to the right places. And we saw something like a reduction from over 30% down to 20% in conversion rates or admission rates for patients with the new standards. And there's a risk that we'll see admission rates go up, putting more pressure on that system and our transformation processes. So I think that's a risk we just need to be mindful of as we do this work over the coming weeks.
Thanks, Bria. Yeah, so I just have a question. Obviously, the Home Office recently released the Right Care, Right Person emergency care around mental health and whether it has an impact on the emergency department. I wondered if in a future paper that was something we should touch on in this report as well.
I think that's a really important point there. I'll take it back to the team and we'll bring it back next.
Any final comments? It's really helpful to track for ourselves the consequence before our targets and what that means for patients admitted, with the consequences of admission as well. It's not without its consequences for patients. So being able to track against that is helpful. Thank you. And absolutely about coming back with the mental health part in the overall strategy. That's helpful. Good. Let's move then to our EDI annual report and to Sabina.
Thank you for your. So I'm hoping everybody's had a chance to read the report. I'm going to highlight some key areas that I want people to kind of focus on and then open to any questions or comments. So the report is a kind of direct response to a letter from the Equality and Human Rights Commission, who's a kind of regulator around equality. And they kind of wrote to all ICB chief execs in February to say we need to show evidence around how we're delivering against our public sector equality duties, and specifically around our specific duties. So we've got 2 duties in the Equality Act. One is around publishing information around our communities and our workforce, and the second one is around our objectives to make sure we've got really good smart objectives around equality. So this is a kind of direct response to that request. So what we've done is just kind of really, it was quite a short deadline, and we did go back to the HRC to say that, and what the advice was that we publish what we've got, given that we're a new organisation and we only have kind of from July last year up to kind of March around what we're working on. So we did kind of deliver that as much as we can. I think we wanted to kind of a partnership approach to the document as much as possible in the short time scale. So we did go out to partners and say what do we want to include in the report. We did get lots of kind of feedback that was included in there. As part of the monitoring from the Equality and Human Rights Commission, they are going to look at work closer with Care Quality Commission, and they're going to look particularly at a few areas that they want to tackle, and this will be in the future months. So the 3 areas that they want to tackle is the inappropriate detention of people with learning disability and autism, action that we're taking to tackle the disproportionate rates of people from an ethnic minority background who are detained with the Mental Health Act, and how we're looking at inequalities in our workforce, particularly for people from Black and minority ethnic backgrounds. So that's what we're going to be kind of focusing on in the future. So just to highlight some kind of key areas where we're doing well, I think in terms of reasonable adjustments, the ICB has made improvements around that. We're looking at more engagement with staff from minority backgrounds are engaging more with us. But having said that, there are some areas that we need to focus on in terms of bullying and harassment for Black and minority ethnic colleagues and disabled colleagues. Career progression for people with disabled people and people from Black and minority backgrounds, and raising confidence in recruitment processes. So these are the areas that we're going to be focusing on in the coming months. There was also some kind of a duty to publish our agenda pay gap, but not until 2024. But what we did was we did make a decision to publish that this year, just to be open and transparent. So that's something that we did, which will, again, we've got some actions around in terms of looking at the gaps and what we need to do. So kind of just to offer to system partners at the moment, what we're offering is we've got an Equality, Diversity, Inclusion Professionals Network. We're all EDI professionals from across the system who want to attend and we'll look at joint solutions and kind of best practice and share some of that. We have a newsletter now across the system, which is called Amplify EDI, so hopefully you should all be getting that newsletter, and it gives updates around what we're doing, how we can get involved. We're supporting the staff networks and organised partner organisations, and really getting people involved in our EDI events that are going across the system. We've got really, really good feedback on going forward. For the next 12 months, we are going to be looking at a few key areas, to finalising the development of the mirror board. I think we've had them conversation for a few months now. I hope we're getting to a place where we're going to start recruiting around that, delivery of some programs around cultural intelligence and reciprocal mentoring at a system level, and then the work around being an anti-rape alliance, which we hopefully taken to the integrated care partnership in a few meetings time to think about what is our approach around anti-racism. And I think the other thing that we'll be looking at is how do we make sure we're responding to that bullying and harassment, creating a culture of inclusion, and as a system, what can we offer around that? So that's where we're going to kind of focus our energy on next year. But if we take any comments, thoughts, questions.
Thank you very much, Sabina.
Thanks, Sabina. It's been really helpful to see the annual report and all the activity that's been going on in the system. And I would just highlight the fantastic system conference that we had back in the autumn of last year. And I think we've discussed, haven't we, about the next event, creating a kind of connection to this activity and the work within the system that we want to build upon and sharing the progress that we're making. And then as a partner from Berkshire Healthcare, thanking Sabina and that conference for kind of lighting a bit of a fire around the anti-racism agenda. And that's highlighted in here with just the start of the journey. But I think a lot about our system work is about sharing the work we're doing. And so you referenced also the Mental Health Act detentions and disproportionate impacts on Black men particularly. We're looking at that in the trust. We'd like to share that learning, particularly with Graham in Surrey and Borders, and no doubt Graham will be looking at that too. So I think there's a real opportunity around this inequality agenda for us, and yeah, commend the work that Sabina's leading. Thank you, Sabina.
Hello, Tom, thank you. I really enjoyed reading the report, so thank you very much. And it was helpful to hear that it ended up being a bit rushed given the externally imposed deadline, because looking forward to future years, I think it'd be great to share kind of an earlier iteration of this board. But really good stuff, and I'm particularly interested to read the example in the Slough Health Inequalities questionnaire, and that was really good to catch up on. I just have one question, and it links a bit to Alex's comments there. And looking forward, I think being clear what our role is for the ICB employed community, if you like, our role as an employer with this agenda, and then our role across the system with this agenda. On the latter, I can see we're doing some really good stuff, but I also just think we need to be clear, where are we adding value to what's happening in individual organisations by bringing people together, sharing lessons? Where do we actually just step back because individual organisations are getting on with stuff anyway? And I felt we could possibly be a little bit clearer as we take this work forward in this and future years. So I'm happy to have an offline course and do that. It's helpful. Thank you. Thank you. Comments, questions? Yeah, thank you. Really, really helpful and clear piece of work. Thank you. Good. Let's move then to the ICS People Programme update. Thank you.
Thanks very much, Priya. There's a few slides that were circulated, so I'm hoping colleagues have had a chance to read those. I'm going to just give some context to some of the detail on the slides. Thank you very much. Is that Sam that's put them up? Oh, Ollie, thank you very much. I'm just going to start on the first slide, Ollie, with the construct of the Frimley System People Board. It's called a People Board at the moment. So our chair is Julian Ems, who's the chief executive of our provider trusts. And we have good representation from some of from the organisations detailed there, and a little bit about the sorts of activities the group pays attention to. The thing I wanted to draw out here was it wasn't just representatives, management representatives who have the staff side, meaning trade union representation in the room as well. More recently, reaching out and deliberately using the word people board rather than workforce or human resources to talk to signal about the agenda that the board looks at. So workforce strategies, of course, but workforce in its wider sense, meaning volunteers, those that enable the workforce strategy and our people's experience at work. So that was just a reminder of the construct of the board itself, its membership, and as I say, importantly, staff representation in that board as well. The next slide was just a bit of context in terms of a snapshot of the employed workforce. So it doesn't include sometimes called wider workforce volunteers in particular, but gives you a sense of the health and care workforce in our system. The numbers will fluctuate, best snapshot at this moment in time. So when we think about our system, I always have those numbers in mind in terms of scale. So 36 to probably 48,000, depending on different people's interpretation of volunteers in particular, or that wider workforce context. So the other point here is when we think about our community, the communities that we serve, then obviously the employment opportunities for those communities. So a lot of our community work in our organisations. It's an obvious thing to say, but rather than separating our community from workforce, again, using the label people to better identify the people of our system that work in our organisations. So as I say, a snapshot, different couple of lenses there on who makes up the workforce, potentially the wider workforce of our organisations. The next slide was just to say there's a lot of data. There's a lot of data about the NHS workforce. There's some data about the care workforce. And the data I just pulled out there is an annual data snapshot of the social care workforce. We look at NHS workforce data, we look at where we can the social care workforce data as both a tool to consider and drive our transformation work, and also notice in terms of compare in terms of the workforce statistics. Is our turnover higher than others? Where are our particular hotspots? So as a people board, we pay attention to that data primarily to help drive the improvement and transformation agenda. The next slide, I just wanted to touch on governance. So how we're constructed. So as a people board, as a work stream, we're sometimes referred to, we account and have the opportunity to escalate risks through the ICB board's subcommittees, particularly finance and performance and quality committees. We also have a requirement to do some direct reporting to NHS England, as well as constructs like the Regional People Board, where the health and care agenda is discussed. I think it's fair to say that obviously the NHS England reporting, now including Health Education England, is dominated by the NHS workforce, be it the here and now performance metrics, or indeed particular strategic areas. The other area that I wanted to highlight was the community of practice. Some colleagues have commented on that. So last time that community of practice met, there was about 40 people on the line, very much virtual, but this is, as it says on the tin, it's a community of practice of people that are passionate about workforce in the healthcare sectors, and come together in a very safe space to say, what can we do better together? So the construct of the board and the work stream and assurance, for example, through the programme delivery group of any funding and the associated projects, but a really vibrant community of practice that shares best practice, challenges each other's, feeds through into the strategic context. The other area which I'll touch on later, there's a specific programme that's unique to our system, called the well, perhaps not terribly exciting, called the temporary staffing programme, but I'll touch on that a little later. Just to say, at its heart, it's a provider collaborative. It's not a regulatory activity. It's drawn from this community that said we can do something better together. I'll touch on that a little later. Obviously, our connection with the Frimley Academy, really important in primary care colleagues. So the dotted line there is just in governance terms saying there's a big community here that's passionate about people, that's passionate about making a difference in terms of both the employment and the experience at work. The next slide, please, Ollie. A strategic context, we've already touched on the Hewitt review. This would just be thinking about, or some of the broader national construct. Perhaps the thing to touch on more is the awaited NHS long-term workforce plan due to be published any day soon. Will obviously impact upon our work as both the system through the people board, and we will pay close attention to when that comes through. Obviously, our immediate reaction is, yes, it's NHS dominated. It will offer some leverage, but we will take that into our system in the context of we're looking at the health and care workforce. The joint forward plan for our system, our work as a people board, I'll touch on that as well in terms of our workforce strategy, our people strategy as a component of the joint forward plan. Locally then, Ollie, the specific contextual elements that I wanted to bring to the board's attention. So as a board, as a collective, as a work stream, we've been going now for some 18 months, nearly 2 years. And what we've been reflecting on is where do we add best value? The workforce agenda is enormous. There are responsibilities that our individual providers, practices have as individual employers. And our job isn't to duplicate that activity. So some of these questions on this slide about what is best delivered at system level? How do we not duplicate activity? What is it that uniquely is within our gift and our control to focus on and aligns with our overarching ambition? You know, the people agenda is obviously not an island. So how do we connect to the our agenda as a system, as a collective, and uniquely focus on and tackle some of our greatest workforce challenges? We don't want to trip over each other. We don't want to duplicate effort. We don't want to spend all of our time asking each other the same questions. So how do we narrow in on the things that will make a difference? The next slide, please, Ollie. Some of our achievements, I won't go through all of these, but I particularly wanted the board to, Sabina's just done a brilliant job of describing some of the EDI activities, so I won't repeat that. I will pick up this temporary staffing programs. As many of you know, I live and breathe and do a lot on this at the moment. Our temporary staffing program started with colleagues in provider trusts in the BOB or Buckinghamshire, Oxfordshire, Berkshire network system with Frimley, and then expanded in the last 6 months to include Surrey Hartland. So this is a group of 10 hospital trusts saying we can do this better together. Why compete with each other? So at its heart, it's a provider collaborative. It was particularly the chief exec saying, we don't want an arms race for temporary staffing. We can do this better together. It started to work. I highlight particularly the activity colleagues in FHFT, Neil's organisation, where the difference of collaborating has included significant reductions in what's called off-framework usage. So better procuring power, reductions in the unit cost, if you put it like that. So what our temporary workforce costs us. It's not about saying the temporary workforce is not important. It absolutely is. But we can do better together, we can bring down costs, we can drive better efficiencies, and what we've been able to achieve through that initial collaboration is now extending across the whole of the South East, and indeed past some capital people today as well. So there's obviously there's some bottling here of the essence of provider collaboratives versus perhaps nationally prescribed ways of doing things. I'll move on just in the interest of time, and hopefully you've had a chance to have a look at some of those other achievements, Ollie, thanks. We highlighted some of the work of the AHP community. One, I'll very briefly touch on the CLEAR programme, we're a fast follower in this area. We're saying that the current construct of the workforce model in some service pathways could be better. We've attracted funding. We're now deploying that programme, evidence-based, into frailty pathways because we've seen it work in other systems. And now looking to extend that across not only our system, but looking to learning with others. Ollie, if you move on, please. I'll skip over that. Oh, no, this is the danger with this. As you, I was describing to colleagues the Anchor Institutions programs, perhaps a wordy program, but a very important pilot that's happening in one of our wards with DW, the Department for Work and Pensions, also with Surrey County Council, where we're looking at brokering employment. Our communities want jobs in our organisations. How do we make it easier? What is it that's in the way? What is it that's blocking? So a really nice bit of pilot work, including other government organisations, county council colleagues, and addressing the issues that get in the way of our communities getting employment with our organisations. I'll skip on to the next slide. This was just saying there's lots of other stuff going on as well. And perhaps if I move on, Ollie, I think our conundrum before I get to the strategy, we don't just look at data, we don't just look at numbers. We say that the experience of our work, of our workforce, of our people is as important as what the numbers that we employ, how often they're absent, present at work. Their experience at work is probably one of the biggest productivity indicators. We've got some great NHS organisations in our patch that we need to celebrate the fact that staff experience is as important to us as some of the other metrics. We have got agreement with our local authority colleagues to bring together data where we have it from social care to build a broader picture of staff experience as well to drive some of our improvement work. The next slide, Ollie, I just highlighted the first staff survey of our organisation, the Integrated Care Board, and again being really proud to show that our staff of this new organisation have the most improved scores in terms of how staff feel at work in this new organisation. We have the highest score in staff engagement, but we're not complacent. There's a lot to do, there's a lot of change, but the top line message here was staff experience was as important to us as how many people we employ and the standard workforce metrics. Lastly, I just wanted to say to the board, we're reflecting on, we've been going for a few years and now as a group, we have a lot of work underway. There's a lot of work understandably going on across our system. We're holding on to that challenge of a few things done well that address our biggest challenge. And this is where we've got to so far. So I'm bringing it to you in draft to say, from the engagement so far, here's where we're landing in terms of some of the ambitions. And the last slide, Ollie, was just saying, we've got more engagement to do. So what have we done? Who have we talked to? Who have we engaged with? What's next? And some of the next steps, all aligned to obviously our system ambitions as part of that joint forward view work. That was it. I can go on and on. Passionate about this stuff and hopefully that gave the board a sense of what's going on through the people board that aligns into this board and with system partners.
Thank you very much, Caroline. Really helpful.
Yeah, thank you, Caroline. I think that's a really impressive report, actually, in the context of everything that we've heard from Fiona. I think to have delivered that kind of change or the sort of foundations for that change is really very impressive. And one of the things that really strikes me about the great opportunities of an ICB is it's encapsulated in your ambition 1, which is the whole idea of creating a joint workforce model for health and care, because we know that the pressures on workforce are universal. They apply across health and social care settings. So just perhaps you could just say a little bit more about how you think that thinking could evolve, and particularly about how we think about not just bringing young people into the workforce, but also thinking about returning workers. Obviously, I'm very keen to encourage people to think about workforce not just being about young people, but also about people who maybe never contemplated working in health and social care previously.
Thank you, Paul. Yes. So ambition one, it's sort of, it's the number one, because it keeps coming back to, uniquely, we as a system can work together to address those common, that common challenge. Where we are with that is picking up, learning from others. So this is something that other systems talk about, other ICBs talk about. So we want to learn from others in terms of where has it been easy to do that? How could we jump on those activities and improve that? You're right about it's about fundamentally it's our opportunity to work with our communities, and our communities aren't just young people, but they're really important. So the construct of who are our communities rather than who is the labour market, just that doesn't do that. Who are our communities that want employment with us, and how do we make that happen? That pilot work that we're doing feels really important to me as a beacon for how we might take it forward. We highlight that over there in that first one, the obvious and well documented issues about pay terms and conditions. So how much of that do we think uniquely we could address versus other issues that impact upon that one workforce model, such as key worker housing, how easy is it to travel, the cost of living challenges uniquely within our system. So this work at the moment, not just to refine the words, but to really hone in on using a logic model or dilemmas model that we've been talking about, feels really important. So yes, our community is made up of everybody, young and old, all different characteristics, feels a driving force, picking the things that we can do together, learning from and with each other systems up and down the country, and then perhaps taking a chance, taking some risks and being innovative in this space because we've done that groundwork first.
Thank you. And sort of back to Paul's question, I'm really keen that we are successful in the outcome for this, so that we can have the appropriate workforce to provide the right place at the right time. I know at the moment there is an element of parts of the system still having some staff in parts of the system moving to other parts. There's a deficit that then impact on, for example, discharges from hospital, etc. And it's really important that we have an understanding of that total workforce, and we collectively have got a strategy for careers in health and care that's at the right number, at the right level of support, and doing everything we can to attract and keep that within the system. Really endorse this piece of work and just really pushing us to be ambitious in terms of the total workforce syndicate, including the independent sector.
And just, just that cost of living piece, and so there's the group of people here very focused around the people that need the workforce, but in terms of solutions, particularly things like key worker housing, that probably comes more broadly from the system, and just I suppose encourage you to, when that data comes through, just to reach out and pull that broader system perspective together on solutions.
Absolutely. The work that Alex knows of this, the work that we've commissioned with our colleagues involved around uniquely the cost of living issues and what are the things within our control, uniquely within our system against that. I think is something I'm happy to share the further detail on that. Key worker housing keeps coming up. It's come up in other systems. It's been a perennial issue. So I think fresh eyes on that as part of the solution, I think it's a challenge.
Thank you. Caroline, I think as part of your pilot, looking at the feedback that I get a lot of is around the barriers to application, both of interviewing and all the kind of process that we have. That's not very inclusive. So I think has that been looked at as part?
Absolutely. I think our NHS provider colleagues spend a lot of time on time to hire, on making it easy to navigate some of the processes. That pilot work is to say it could be better, actually brokering the employment conversation, because people are telling us those application processes are still too hard. In fact, they feel archaic. My son, my daughter, who's going through an employment experience is used to AI, is used to uploading materials in a very different way. So the short answer is yes. The longer answer is again, the challenge we place us to the people board about what uniquely can we do, given some of the national constructs around this, some of the opportunities that will be driven through other decisions. But yes, it's very much firmly in that world.
Thank you, Richard, and then Max.
Thanks, Chair, and thanks, Caroline, hugely impressive presentation and work. I'm really interested in turnover rates, and I guess it might follow on a bit from Sabrina's question. So turnover rates have come down since 18, 19, 20. Do we know how we benchmark against other areas for health and social care staff turnover? And do we know why staff are leaving where they're going to?
That's a really good question. So yes, we have the data. There's different data sources. So I showed you the social care annual survey, and I often look at that and very glibly perhaps say, if we think we've got it in difficult, and then in the NHS, have a look at the social care turnover rates. So yeah, we have the benchmarking data. Some of it is nationally published, some of it is management information only, but that information is shared between us as organisations. The exit survey analysis, there's a piece of work that's just been done by the Health Foundation, Anita Charlesworth, where they invested in we might be leaving, we might understand where they live, but where do they go to? So the Health Foundation is the first set of analysis I've done really, really robustly that tracked nurses and said, where are they going? How many stay within the health and care sector? How many go into the... So we're looking over that piece of work at the moment, adding to our own exit interview information. Jane, the HR director in Alex's organisation, has done a detailed piece of analysis just for your organisation around tackling the number of unknowns. So when you leave an organisation, there's a box that's ticked. The highest across the South East region is unknown. So the work to tackle it's not good enough. Where do people go to? BHFT have done a great piece of work on that. There's some changes happening to the national ESR platform to make it reduce the number of unknowns. And then we've got significant research pieces that tell us, like the Health Foundation, well, where do people go to? I don't have that for this system. There's nothing available in the South East, but we've given it to the regional team to say that's the sort of stuff we need to inform our work. The staff survey, of course, is probably the richest source of my experience, my intention to leave rather than just when I'm leaving. So the notion of itchy feet, how do you capture people before they leave? How do you understand people quietly quitting before they actually go? So yeah, loads of data in that place. Yes, the benchmarking data, health and care, and it's a significant data source as we think about, well, what is it that the work of the people board should be focused on?
I think that's huge. Thank you. Clearly, turnover costs money and turnover. High turnover rates mean potentially experienced staff leaving, and there's something about that level of experience. I'd be really interested to see that data when the work's been done and how it could be targeted, and particularly where experienced staff are leaving. So it's going into numbers of nurses.
Yes.
But the level of experience is vital, I think, the level of patient care.
We're at quite a potential risk and tipping point for the workforce, aren't we, given what's happened with the pandemic, loss of living, the pressures emerging post-pandemic into the health and care workforce. And I can see very clearly the strategic objectives here, the drive to get more people in, retain the people we have. But I think there's quite a strong wellbeing angle to the strategy that we need, and I can't see that loud and clear in there. And the wellbeing piece, certainly from our perspective, is a key link to motivation, engagement, and positive experience. So it's just an ask really to see how we might develop that in this context.
I think there's also a productivity angle. I'd say a 1% reduction in absence because you're supporting people, health and well-being.
Yeah.
You know, your average hospital equals just under £1 million worth of savings. So the productivity angle on that, but fundamentally the engagement and morale and motivation. Yeah, but absolutely, I think we'll pick that up as part of the feedback into it. Let's amplify that a bit further in those ambitions.
Thank you.
Thank you. That's been a really helpful conversation about a key part of what we're about in system working. So thank you for that. Let's move now then to our performance oversight report. And Richard, Sarah, Caroline, would you like to highlight any particular elements, or can I move to questions? And so may I have comments, questions, please? These are reports that have been through a number of the board subcommittees. So thank you very much for the reports as they've come through. We would now have questions received in advance from members of the public. We don't have any questions for today. Is there any other business? Can I go around? Table? Thank you very much. Thank you, everybody, and thank you for our members of the public who've joined us today.
Thank you. Thank you. Thanks.
Welcome, Sam.